Welcome to the award-winning Leadership in Business podcast, an official podcast of the American Neurological Association. We hope you enjoy this special episode from the AUA Coding Seminar Webcast, featuring the panel discussion, What Practice Managers Wish Providers Knew About Revenue Cycle Management.
We are going to invite all the faculty back to join in this panel discussion, What Practice Managers Wish Providers Knew About Revenue Cycle Management. And I've been doing my thoughts on this, and I'll share what I wish providers knew in just a little bit, and it might surprise you. So our learning objective for this part of the session is just to identify key areas where provider engagement impacts revenue cycle outcomes and define communication strategies to align clinical administrative workflows for improved reimbursement. So I think this hopefully will bring together a lot of the conversations that we've had throughout the day. The first thought-provoking question that we have here, and again, this is open for the whole faculty to take on, but when we think about gaps and gaps in the entire process, as we've identified, it is quite a process. What are some of the most common ways provider documentation could cause delays or denials?
Well, I'll go ahead and start that off, and then everyone can go down the list if that's all right. When I think of two things, which I talk to my co and fellow providers about, the two things which I stress is not as much the documentation is causing delay or denial, but they're not closing out their charts and not getting their operative notes in a timely manner is what is one of the biggest downfalls to a lot of provider groups. We have a unwritten or sort of a partially written rule actually that says that all documentation needs to be closed off within 24 hours, including operative notes. Listen, hospitals do it, and we get those us providers get the nasty letters from the hospitals if we don't don't get the operative notes in right away. But I think that's true for revenue cycle management. I just got to believe that if I can close out all my E&M charts by the end of the day, close out my surgical procedures by the end of the day, my coders are happier for me. I know that's not documentation per se, but that is just something which I want to impart on everyone out there. The ways I think prior documentation leads to denials delays is the doctors not truly understanding coding as well as they could and making assumptions on what should be billable in an effort to try and maximize their RVUs. I mentioned earlier that I just got this email about somebody who wants to do a scrotal exploration when doing a vasovasostomy and why that doesn't work. Otherwise, we do scrotal explorations and vasectomies, scrotal explorations, and that doesn't work that way. But they don't realize it. And when they'll put down 3, 4, 5, 6 potential CPT codes on their operative report, which then takes the billing staff probably a long time to try and get through to see what is actually reportable or not. Then they have to look up and seeing what is bundled or not bundled. So I would imagine that if we could get providers to understand how that affects the downstream work, and then at the end of the day, what that affects their bottom line, I think would be very helpful.
I think that's terrific.
Oh, sorry.
Go ahead, Melanie, please.
I think that's totally right. I think the practice managers, as a practice manager, as a business office manager, any coder, anybody, we just want the providers to know that they can trust us. We are on their team. We're not nagging. We're helping their reimbursement. We're wanting to work with them to get the reimbursement into the practice. So we just don't walk up and say something if it's not necessary. there's reasons behind that. So yeah, I would like them to know that I'm on their team. I'm helping them. I want to help them to protect their revenue. If that is by me saying, hey, your documentation needs to be faster, your documentation needs to be clearer. I mean, that's all stuff that affects the revenue down the stream and basically their pocketbook. And yeah, we're on their team.
Yeah. So Melanie, what's interesting, I just want to piggyback off that a little bit. I just want to tell you about the personality of physicians and especially surgeons. So, it's really interesting. I don't know why it is, whether it's that personality that's drawn into surgery or whether it's drawn into medicine or the way that we've, put ourselves on a pedestal. But it's really fascinating how challenging it can be sometimes to try and communicate in a collegial way to physicians. I mean, heck, even me to my co-physicians, I have people snap at me when I try to help educate them. So my recommendation thought is that physicians will probably best hear the coding advice from a fellow outside physician, from a nationally known coding expert, reimbursement expert who's on their side, from the American Urological Association, or from somebody with a C, a CFO, a CEO. And oftentimes, if there's a practice president, I think one of the best ways of doing it is to get the practice president to buy in, the physician practice president to buy in. If the physician practice president, who hopefully will be the one who understands how cash flow goes through, who understands the importance of documentation, who understands these coding nuances, can help have that discussion with a physician that isn't doing as well. I just feel somehow that hits a little bit harder, and I'm sorry that it's like that, and it's terrible that it's like that. It's sad, and I apologize on behalf of my own profession how it is, but that's just the reality of what it's like in medical businesses. So the best thing one can do is to align yourself with a leader who will take advantage of that.
And I'm lucky in our practice. I've been working with most of my doctors for almost 20 years, and they've learned to trust me. So for me, that's not a big deal, but I hear that quite a bit when I talk to billers and coders and people that work in the business office that have to talk to the providers. So for me myself, it's never been an issue. We work really close together, and when we do the physician education, they ask the questions, they come ask questions. We have a really good communication. So in our practice, that's not necessarily the fact, but I know that I hear that a lot.
One of the things that we do is our providers all have their lead medical assistant. Well, in our practice, they also have a lead patient service rep. And part of the responsibilities of that individual is to maintain their schedule and to circle back after the day and make sure that everything is signed off and out the door. So it kind of completes that team, and we've been talking a lot about teamwork and feedback loops, and they're very much a vital part of that. What I wanted to say earlier is back in the day before EMRs, and when we were making the transition, our surgeons used to run around with coding slips in their white coats, and so we always had to track them down, and we wouldn't let them leave the office without emptying their pockets, because we would have to equate that every single slip of paper that was in their coat needed to be turned in so we could actually get them paid for that work and to turn it from a white note to a green note.
I remember getting charges on like the exam table paper, like level 4, and like tossed on my desk.
So, we used to do that for hospital. So we're, since we're mostly office based, so when people go to the hospital and see consultations and follow up patients, we have like, the billing sheets that we would have them, fill out. But the couple issues is, one, they have to remember to fill it out. So that's the first step. Number two, they have to remember to turn it in. And three, they have to remember to turn it in a timely manner. Because, for me, seeing part of how this works, if you're seeing consultations, if you're seeing, all patients in the hospital and you're not turning that billing, you're giving away your time for free. And that's not how the system is supposed to work. It's supposed to work where you're paid for your expertise. And this is what people spend all this time and money to get these degrees. That this is how it works. I had to get in one of my partner's cars to get a ride someplace, and I went home and they had a stack this high of billing sheets that didn't turn in, and I groaned and I said that we'll sneak in the back door so that the C-level people are not going to get on you too badly about this. But it's tough to keep. It's tough. I think that's more more than just documentation. It's just turning it in a timely manner. We do have, again, when we're talking about using the powerful EMR system, all of our scheduled surgeries are in the EMR, and so we can do encounter tracking for when those are not billed and closed out by our providers. It's the emergency add-on weekend evening cases that we have a harder time capturing.
Absolutely. We've partnered with our hospitals, so they send us those notes anytime a provider's in the hospital. So then we were able to circle back around. In our chat, the next question is, where do we think providers underestimate their role in the revenue cycle? And Susan puts in here that she thinks providers may underestimate their roles in the revenue cycle by not understanding payer rules and medical necessity requirements.
Yeah, it's another great opportunity for education to providers. We talked, Jacob was talking about, the high dollar items, which, in urology, I'm thinking about like sacral nerve stimulations, penile prostheses, and certain other, things that require a big cost of some sort. And a lot of insurers, have very narrow focus and rules surrounding sacral nerve stimulation. Sometimes the people meet the rules, but either the provider doesn't know the rules, or they meet the rules but don't document it. And either way, we're probably, those are the types of things that get audited the most, those high dollar items. And so if, the more we can get that out, but again, that's another communication piece. A provider wants to do I'm going to use sacral nerve stimulation as an example. They want to do sacral nerve stimulation, and they really mean well. They mean the best, and they want the best for the patient. So then they go book it, but then it needs to go through a prior authorization team, or potentially through the revenue cycle manager people first, so they can then double check and make sure that the patient has failed whatever conservative therapies, doesn't have a neurologic cause of their bladder issues. So it is that's when we have this communication. Again, that's when the providers get frustrated if they can't go through with it. But that's the opportunity for somebody from billing staff to reach out to the doctor and say, hey, these are the rules, and I really want to stop you, not stop you. I want you to understand what these rules are. That's a great point.
So something that we've done, especially with these high dollar bladder cancer therapies, is we've really, in our practice, developed a team approach with this. And there's several requirements that need to be in place to make sure that we're paid. And the price tags on these therapies, while they may be wonderful, is extremely high. So one of the things that we do is we have a partner just review the order to make sure clinically that it's indicated. After that, we have within our ordering for all of our medications happens through our IOD, they initiate the process with the industry, whatever their process is, and then our revenue team also looks at it and starts their process. So we have 3 checks that are going on simultaneously from 3 different angles to make sure that we are good to go. When we first started, there was a lot of enthusiasm to get going on this, and what we realized is when one of the partners took a look at it, the enthusiasm preceded the finish of their BCG regimen. So we've had to throttle back and make sure that we were checking all of the boxes. And I think that's where, as Dr. Rubenstein had mentioned, having some, physician level communication, it just comes across a little bit differently sometimes if it's even myself or, one of the billing team just saying, hey, doctor, we need to think about this a little bit more. Watching the questions here, there is one that says here, when do you suggest the appropriate time for providers can complete their surgical notes? We have providers that send several months late. Dr. Rubin said 24 hours. Yeah, the hospitals are on them. There's no reason why we as a practice shouldn't be either.
Yeah, it's actually a violation of our hospital bylaws if we do not immediately write at least a brief note. And I think it's a violation of the bylaws if you don't have the true operative note within 7 days. And, we as practices don't always set those things up. We don't, we need to police ourselves and enforce ourselves. It's different when you have the hospital enforcing us, but even within our own groups, we need to be able to almost like reinforce between ourselves. And I really, again, think that comes from like a practice president and, a business manager, office manager who needs to figure out a way of getting everyone on the same page, understand the importance of it, because it really affects the bottom line. My thing about, documentation, and again, here's the whole part about operative notes. I'm not sure if I remember what I had for breakfast today, let alone remember the nuances of what, I spoke about with Ms. Smith 2.5 weeks ago. So there's, increase our quality of getting our charts done and operative notes in within 24 hours. It allows us our best chance to remember exactly what's going on in the nuances. It allows us to start getting through the revenue cycle system as early as possible. And it does really affect our bottom line. I mean, if you had a group of 8 urologists, and one of them was dragging behind, that person is actually dragging the other 7 people behind. And I don't think that's fair to the other 7 either. So it's a whole team that all needs to agree on the importance of getting it in.
Yeah, there's a couple of components to that as well. One is, I've never seen from the consulting side, work with multiple clients. I've never seen a written policy for a client that's over 48 hours. So it's either they don't have one and providers just don't have a guideline, or it's well under 48 hours. The second takeaway is these are all internal guidelines. Remember, our Medicare guidelines for signatures and documentation basically tell us it has to be done timely. Without any indication of what that means. So this is all kind of self-driven. But the key here that I wanted to expand was the rules for submitting claims with CPT codes is that there is completed and signed documentation. Although we're allowed to have attestations in some cases, we really shouldn't be dropping claims without completed and signed documentation. And so sometimes those, will get through the system without it being completed. And then you get into situations where all the records have addendums and we start to get those contradictions we talked about earlier. So it really can become messy very quickly when we start adding addendums that impact reimbursement is a norm and not the exception. And to your point, there's a lot of feedback that happens when there's a delay and things get forgotten, or, the details of that encounter are captured as quickly as possible.
Yeah. I'll add as well, a lot of people are now dealing with managed care companies with prior authorizations that it's really hard to get a reauthorization. So not having the documentation to get a change, or not understanding what should have been billed to get a change in the prior auth is an effect on the overall reimbursement. That is a timely issue that we need the documentation to actually wrap that through. And I'll also, the other thing I will add in all of this is, physicians ultimately think of, one of their biggest complaints on burnout is documentation in the administrative tasks. So it does make it more difficult. But the reality is, it is a part of the job as a physician to make sure that documentation is there and it's clean and it supports everything that was billed and what you're going to collect for. So it does require a little bit more enforcement and team effort from the management side to bring your physicians into line, and it's not an easy task. And then the other thing I'll add in all this is, most physicians really touch about 40 codes that they deal with. And, a lot of times we focus on teaching them a lot of things, when in reality, what they really need to know is those 40 codes that they deal with. And, if we can either get them to filter or we can filter our messaging to them, I think it helps as you get through that, because they really don't need to be coders. They just need to be able to code what they do.
I like that. Code what you do. Learn. You're right. You don't have to learn all of urology coding. You have to learn the codes that you do and what's important about it. So that we got to set the practice, revenue cycle management up for success the best that we can.
Yeah, which is, I think, a great segue into bridging the gap. What are some things you wish you could explain to providers about coding, billing, denials that would make your job a little easier? Which is, I think, kind of what we've been talking about this entire day.
Yeah, I think it's just knowing mostly it's gonna be what's included in a code and what's not included in a code. Because again, that's everyone does want to try to maximize their appropriate RVUs and reimbursement. Totally get it, but they have to know what's already paid for in that RVU that they're getting. Because I think again, one of the I agree with the comment. Says something a provider got frustrated, or a provider gets angry or upset, which is true. They get very emotional, especially when it comes to reimbursement, and they get very emotional when they're told that something's already included, because they heard that, hey, some guy down the street's doing that, or this is how I was trained, this is the code what I used, but to actually know it, and they have to go probably to a talk and listen to this EAN talk and this CPT talk so they can know what is included in the code, so they can, again, appropriately talk about, here's why I should get paid for these two things, because I knew what was in each one.
I always kind of equate it to being a tax accountant. I'm like, we have the same goal here. I know the rules. I'm trying to maximize what you can get, as efficiently as we can. And I think that relationship, having a shared goal, is kind of what I wish was a little more clear, because it's hard when you're the one always coming and saying, no, you can't do that. No more money for you. No RVU for you. It seems like it's against the provider group, and it's really out of protection, whether that's, protection for the provider, because generally it's the provider's MPI that is being used, and protection for the organization. And so it really is, I want this to be maximized for sure, without the risk. Right. And we need to balance both of those, that it is a dance between maximizing and reducing risk.
I think a lot of it comes into the culture of the practice and in being collaborative and not confrontational. I'm very fortunate that within our practice, it is not a confrontational situation. It is very much a an open and collaborative, where if somebody sees something and they say something, it's not a slight against the provider or a slight against the any of the clinical or support staff. It's very much, hey, we might be able to do a little bit better job if we did this. And the comments go both ways, which is I think is very important.
There's a few things that are just plain dumb that we need to document, right? I mean, and ultimately, when you're bringing that up, and we ran into a few recently with, XIAFlex, making sure that you document the wastage, right? I mean, you know what was injected, you know what the overall, somebody else could calculate that. Well, I mean, the racks are coming back and they're saying, no, you've got to take that time to calculate the wastage. We're looking for that JW modifier, like pushing that back to where it belongs in the clinical record is not something that's an easy task for any of us to do, because again, we're asking physicians who are busy doing what they're trying to do to put this little ticky-tack stuff in there. But that the fact is that has to be in there. If you want to get paid, or as a physician, if they want to get paid, we've got to follow all of those rules. And I think that ultimately a lot of physicians think that, well, it's all you're doing is pushing buttons. And that's not the case. I mean, it's monitoring things, it's trying to communicate, it's trying to deal with their schedules. And if they would actually take the time to understand, again, that we're on the same team and that these things are not dictated by the coding team internally, we are trying to adapt to what the market is to get them paid the maximum and as fast as they can. If they'd play the game with us, because it is a game, and maybe that's from the organization building a little more time into their schedules for the administrivia that is required. I mean, that's a part of the game. It's not paid for, it's not glamorous, but in the end, without it, you're dead.
Right. So, Mark, if I remember historically, and I may or may not remember this correctly, and the one thing I would say as providers, some of these rules that are put in place because we did it to ourselves, or maybe not we, but a couple bad apples, spoiled a whole bunch. If I remember, I think historically, it was a group of people working in a dialysis center that were using Epogen and dividing it, using 4 in one vial instead of just 1, and then they would charge Medicare 4 times for it when they really should have only been charging once. And I think that this was a huge waste, something along those lines. And so therefore Medicare says, okay, anytime we need to know how much you're wasting to know that you are not wasting Medicare's money. So it was a bad apple, spoiled a whole bunch, but unfortunately that bad apple did spoil it for everyone to have to do this documentation. And it's extra work, and it's busy work, and it's unfortunate work. I'm not trying to take CMS's side on this at all. It's just unfortunately the reality of how medicine is right now, and Medicare not wanting to pay unnecessarily for stuff against their own rules. And it's sad that it came to this.
It is. And now that's part of it. And the other part of it was Medicare and really trying to go after the pharmaceuticals for their packaging piece. That was the other one that stepped in. So it was kind of those two things compounded that they're looking at. So there's always, no, I shouldn't say always. There is most of the time some basis in logic as to what they're trying to do. It doesn't always make sense, but there's almost always a reason that they're jumping on these little ticky-tack things that are out there to try and drive some other outcome. And we need to, it's a game. It's a chess game, and they rewrite the rules routinely, and we have to stay on top of them and keep feeding that back through the system so that we can all make as much money as we can, because everybody's busy from top to bottom in every urology practice that's out there. It's, the physician's busy, yes, but so is your AR team, so is your front desk, Like everybody is working hard to support the system, and a little respect on those things, I think, is also warranted.
Which kind of brings us into our next bullet point here. How can practice managers better support providers in improving their revenue cycle management outcomes without adding more to their plates? And I think that's a collective their plate, as Mark has just said. Everybody is jamming pretty hard these days. We have a note in the comments. It says practice managers can improve RCM by supporting the providers through focused efforts by streamlining workflows and communication. Communication is key. Have regular have educational sessions and regular meetings.
I'm going to pull in Stacy's comment here about diagnoses as an example of this. So Stacy mentioned that she thinks that providers using unspecified diagnosis codes and not understanding ICD-10 guidelines is a challenge, or that would help make the coder or practice manager job easier. And it brings me to this point of having that collaborative relationship, right? Understanding both sides, having that relationship with your providers where you can let them know what happens to those diagnoses after it leaves, once they enter it in their record or the EMR and it shoots off, what happens to it, right? And it's like, well, every time you use that unspecified diagnosis, it comes back and somebody has to manually touch it, or we have to come back to you, like really outlining that process. But then on the flip side of it, there's so many coders, billers, claim edit resolution, denial specialists that have never had a physician encounter outside of them personally going to the doctor. They've never had that shadowing of a provider. What is it like? What is your view in the EMR like? It's different than mine. Clearly, I can't write a record. What is it like? What does it look like for you? What is it like to be a provider trying to build an assessment and plan? I was so fortunate to have that relationship very early on in my career and get that understanding, but not everybody is. And I think that's where that relationship can go both ways. And so practice managers, to kind of come in for a landing, or even our administrative staff, can really start to facilitate that cross relationship where your revenue cycle staff is learning and understanding and able to have empathy from the provider side, and vice versa, where your providers understand all of that admin work Mark just described that has to happen to, after the provider's done with their piece, and really being able to zoom out and see that full revenue cycle for everybody, starting with the provider's work and ending with that admin work, I think is incredibly important.
We do job shadowing between our clinical, billing, and support teams. And it just, when you made that comment, Jacob, that's why should we limit it between the non-providers? Why not have a biller shadow a provider for a morning? I think that would be as equally, if not more powerful, to help shed some light. And anytime a provider checks in or spends a little bit of time with our billers or our support team, that's like gold. That just helps reinforce that relationship and helps them be seen. And the providers are always seen as kind of the working end, the heroes of the practice. But anytime they pay attention and offer support and to any of our hourly employees, that is always met with great respect.
I think to that point, it's important to humanize these relationships, right? We do all this communication through an EMR, and it's just an in-basket message or something like that, like, hey, this code is wrong, or watch this PowerPoint or something, and it really creates this like online kind of Facebook argument environment, instead of we're two people with two responsibilities that have different skill sets that are part of the same team and goal. I think that's really important.
Jacob, that's such a great point about having a personal relationship and knowing who your coder is and who the RCM team is, because then it turns into friendly fire which is also very helpful. So Melanie, you may be working sort of in an office where you know all your providers and you see them every day. There's larger groups that the RCM staffs in a halfway across the state, and they communicate through computers only, and so it's a very different and more challenging relationship that way. My practice is a large urology group practice, and we actually had our head person for our IT who helped bring our electronic medical record system, many years ago into our practice. So she knew how to run the computer. She knew a little bit about revenue cycle management. I taught her everything she knew about coding, and we would build the whole system together. And so she learned almost every disease process and every new technology so she could build those modules into our EMR system. And then she goes to our revenue cycle management and tell them how they need to get billed. And so she's been our liaison between the two. So yes, it's nice to be able to have direct communication between an RCM team and the provider. But again, I train all my new doctors when they come in. She also trains the new doctors when they come in. And we set that expectation for they're supposed to be them closing the charts, and us giving them the education that they don't get during residency can be very helpful.
Yeah, while you kind of leaned into tools a little bit, and Jacob did earlier, that's another thing that goes untouched for too many groups. If you've got unlisted ICD-10s coming through, there's another piece of that puzzle in the IT world that might be able to remove that as a choice on their short list. So staying on top of those things and repetitive errors, Jacob mentioned that in the audit side, identifying where the tools can be used to help eliminate those are huge. Tools are tools, but they're only as good as their last update and as well as they're maintained. So that's another big piece, I think, that we can leverage to help everybody move some stuff off their plate and get to the end result a little bit more quickly. Templates are another one you mentioned, Jacob. That's another one that misses the boat that can be updated. And it does take time and somebody to circle back around to actually keep those things up to date and functional for today's world, which is moving.
Real world scenarios. I had mentioned the providers walking around with the charge slips in their pockets, and is there any other current situations that we may be dealing with or want to talk about a little bit?
If you want to get really detailed about urologic coding, the biggest gripes I think from my team had been not putting down the size of a bladder tumor, because there's three bladder tumor resection codes, and at least writing down what the size is of the tumor that's being resected has to be in the operative node, or has to be someplace that can be found to know if they're not choosing their own code to, then the RCM team is going to need to go back and have them put that documentation in. If they do choose their own code, it's the RCM team who then needs to look and see if they actually wrote those words in someplace in the medical record so it can be supported. So again, providers knowing the codes, RCM team making sure that it's in the note before it goes out the door. And again, that helps support our reasoning that we shouldn't be sending out bills to an insurance company without the documentation first.
I think that's such a perfect summary of what we talked about, of having that full scope of the revenue cycle in that relationship, because it brings up, as the revenue cycle team isn't creating this code set, these are the three options I have to put this service into. It requires certain information, but that's just the process, right? And there's often not that link. We have all of this ancillary education that happens with providers, and it's never the direct, here's the three options for this procedure, and here's what's different between those three CPT codes. This is what needs differentiated in the record. Working backwards from the system instead of into it can be helpful sometimes.
The other thing that
goes into one of my notes that I wrote down. Don't let others guess what you did. I highlighted that. That's a huge takeaway.
Yeah. So the one thing that we're seeing around the country, and Jonathan, you brought this up a little bit before, is in larger practices, the physicians get more and more distance from the actual revenue cycle side. And you add on top of that the turnover that we're seeing in workforce. That is a big disruption across the board. And so, one of the things I would recommend is, in addition to having those procedural protocols for the docs to finish their notes, the communication protocols need to be there as well. So there is some consistency across the organization on how communication works, whether those and what the expectations are for everybody to try and get them all on the same page. And it's becoming more and more important as we leverage more and more tools, and it is less personal, as Jacob mentioned, the process of messaging and tasks and all those things. It's easy to get mad at who fills up your inbox, but it's also the flip side is if you don't answer your inbox, it's going to get full. You gotta be part of the solution, not part of the problem, for both sides.
Thanks for the attack on my Outlook inbox, Mark. Appreciate that. No, I'm kidding.
I'm sure it was attacked fully
it's
beforehand.
True, though.
There's nothing that I did today that actually leveraged more.
The problem is these days that you don't only have you have the communication within your EMR, so you have the tasks. You have Teams messaging or whatever your practice decided they're going to use to talk to each other. You have your email. You have possibly the phone ringing. So, stuff gets buried. So communication in a large practice, I don't even know how you can keep track of all of that. I know that between my email and my Teams messages, you are gone for a half a day. And when you come back, it takes you 2 days to dig out from what you had. So it's not that easy. I know we always try to do provider education through Teams messages. It's not that easy. And I actually go around and check and make sure that people have read that, or if they would rather have me print it out, because it gets buried and you sit there and you go, man, I sent them 5 Teams messages telling all of them that they need to document the size of the lesion. Why do I have to say it again? But it gets buried in this day and age where you have all these different avenues of communication. It's really tough to make sure you're all on the same page and that you decide how that communication works in your practice.
It's sorry, I just kind of lost my train of thought, which I was going to get. I was going to pivot off that, but I'll get it back in just one second. I was also reading the comments, and someone was asking about PCR culture building, which is a whole nother topic. And the problem with PCR culture building is that there's a lot of it's a challenge. We'll just say that. I don't know what the future is going to bring for it. I think that there's have been some pushback on it, on the real utility over PCR cultures, and for what we want them to be and what I think they're going to be in the long run. We're going to see if this pans out or not, because I don't think there's been enough great data to really support its use in a lot of situations. And so I don't mean to be negative about it, but I'm fearful of what may or may not happen in the future for it.
Yeah, no, I'll add the theoretical is great on PCRs. The real world and the differentiation is what we're having a hard time proving. And so I saw a couple of questions earlier. The coding is one problem. You've got different payers with different focus on how many unlisted entities you can do, or whether you have to bill in a group. And then the secondary issue is really, is the PCR far better than a culture? You know, when you look at a culture and sensitivity and the way antibiotics are prescribed in real world versus the PCR, I think that's where we're having some difficulties. I think the theoretical that we can at least get the right antibiotic in the right hands of the right person right off the bat is there. The question is the juice worth the squeeze to the system? And if the pricing came down in PCR, it'd be a non-issue. But it is one of those things, and I can tell you after reviewing tons of rack audits on PCR, you would better have a very good reason why you did a PCR over a culture and sensitivity, or they're going to be coming back after a lot of your money.
Yeah, I agree with that.
You got paid.
Okay, it's back on topic really quick. Melanie, now remember what I was going to pivot off. So, you know, another thing, which again, we sometimes the physicians are not trained, are really our organizational skills and executive functioning to be able to get those inboxes closed. And, you know, listen, I'm hearing the same thing, Melanie, Jacob, Jamie, you know, listen, same thing, Melanie. If I take half a day off, I turn on my EMR, you know, the number of messages and labs and, you know, patients want to hear back from their doctor within 7 minutes of them calling. When I first started practice, I would go away for a week. I'd come back. I'd have a stack of little tiny notes. Please call this patient back. They know I'm gone. And this day and age, if I don't, you know, if I'm not, don't call back within the hour, they wonder what's going on. So it's a different world now than it was 20 years ago. And the skills I think that are really make a very successful practice have some of that executive functioning of like, hey, we got to get these charts closed. We got to move on because you blink, you have another 20 messages that are going to pop up. And Mark, just like you were saying, you know, it's that's what happens if we don't get these things closed. And there'd be no better reason to remind people, because once it starts, you know, spiraling, it spirals pretty quickly. So that's I just can't encourage people more than to get it closed and to have a policy. Jacob was saying there's some places just don't have a policy. We have a policy. You know, we enforce it when somebody's really, really behind. We nudge them when they're kind of behind, but it's there. And I think that's just important for all of us in this day and age of medicine.
It definitely takes a team. And there's a team member that I don't know that we've spoken that much about, but we do have Susan put this in here about educating patients about their out-of-pocket costs and payment options to reduce confusion and billing disputes. I think involving the patients in their healthcare is huge. I think they have to be an active participant in what is going on. You know, we need them to be involved, and if we can educate them and help them understand, I think Melanie had that as part of her presentation earlier, is being upfront, setting those expectations so they know what is involved with their care, and sometimes their plan may require you know, several steps along the way before they get to definitive treatment. They should know that. I think that's a member of the revenue cycle team that we should never neglect.
Yeah.
There's some interesting compliance considerations with that topic, which I think are worth pointing out. So, you know, it's not just the patients that don't fully understand the cost implications of some of these services. The providers can use some information on it as well. And, you know, I want to point out an example, you know, might be not urology specifics, but like two services, you know, where it's like, oh, I know the patient's going to get a bill for that, so I'm not going to do it, or I'm not going to charge for it or something. And it comes from good space, but without the proper understanding of the implications of something like that, like you could be in violation of other compliance rules, or, you know, even looking like you are prioritizing certain populations of people and not charging tall people or something like that. And you know, so there's a lot of implications around the revenue side of this that, when you have to give the full picture. You can't just pass on a little bit of it. You got to pass along the whole booklet of details around what it means, because people will naturally form their own conclusion and their own way around certain things, providers included. And so, we want to make sure that we're informing to the highest extent when we are discussing, co-payments and out-of-pocket costs and potential costs for additional services, and utilize your processes for that. I think we have processes for Medicare in terms of like ABNs and things like that happen. We can utilize similar, formatting and conversations for the same, that same topic with other payers and other populations.
Thank you for listening. To enhance your knowledge and proficiency in urologic coding and billing, receive essential urologic coding and documentation updates, and explore the impact of accurate coding on revenue cycle management, check out the complete AUA Coding Seminar Webcast on AUA University at auau.auanet.org. Until next time, continue to learn, lead, and excel.